All right, here we go. We're going to enter the world of critical care. Now, this is either going to be where you love or hate it, okay? And you can see on here, this is graphic. This is critical care. See this right here? That's real blood. That's not fake blood, okay? This is an example of critical care. Let's get a base of knowledge so that we can learn about the patients that go into critical care. Now, you may not be an individual that cares for critical care, but what you need to do is we need to kind of break that black box. So you say, as you may be taking care of a patient, you say, I hate critical care. So I take care of them on the wards, and then I push them to the critical care team, and then they kick them back. And it's like a black box to you. You don't really know what's going on, but you really need to know what's going on so that way you can take care of patients, or you may be in a situation where you have to take care of these patients. All right, so let's go through the real world of this. So we can have this black box of the ICU as patients come in and come out. Another thing you have to think about is those patients who survive. So roughly 35% of those patients who are mechanically ventilated in the ICU survived their hospitalization. Guess what they had? PTSD. PTSD from their experience. So they've gone through that black box. You said, oh, they're sick. The critical care provider takes the patient, gets the patient better, come back to you as either an inpatient or outpatient. And guess what they have a high risk of? PTSD. So there's things we need to think about. So another example of the black box. You ever wonder what happens when a patient gets urethral stenosis? Well, I'm not going to tell you graphically what goes on, but you can see right here, that's tissue. That's tissue, and you can imagine what happens with this so that the patient no longer has urethral stenosis. So this is part of that black box that we need to have an understanding of what our patients go through. I imagine that most people would have PTSD from just getting this procedure if they're awake and they're experiencing this. All right, let's go with one of our questions, our famous questions. We're going to look right here. Let's do right here. Let's go to the answer first. And let's go. What is the most appropriate next step in management? All right, begin N-acetylcysteine. Observe and repeat liver function tests in 12 hours. Administer active charcoal. And begin corticosteroids. Immediate liver transplant. All right, so you see if this question is fair or not. And guess what? Most questions are not fair. So these are things that we have to learn to get over. When you're taking a question, I want you to get rid of that sense of justice. Is this fair? Or is justice happening? I would just want you to think about, let's get through this exam and do well on the exam, instead of, is this justice? Is this question right? Is this question fair? No, they're probably not fair, to be honest with you. And the percentage of the questions that we talk about here in this review session, they're not fair at all. They're not right, they're not fair, but they're board questions. So what we're trying to do is get your brain to think. All right, so let's talk about this. Is a 52-year-old man with chronic lower back pain presents with malaise, nausea, and right upper quadrant discomfort, right upper quadrant right here. Now he reports he's taken 1.5 to 2 grams of acetaminophen every 6 hours for the past 5 days for pain control. All right, so that's probably a little bit higher than we would want them to take. So what do we want him to take max? So he's taking, we're gonna say 6, he's taking about 8 grams a day maximum. And we probably want to keep them in the 3 to 4 range. Now remember, if they have liver disease, we want to keep them in the 2 grams or less, okay? It's 3 to 4 in someone who doesn't have liver disease, and we'll say less than 2 grams in somebody who has liver disease. For his pain control, and he was prescribed hydrocodone acetaminophen, so he's also getting acetaminophen from there. So guess what happens? He gets his studies, and guess what? He has an elevated AST and ALT and elevated INR. So his liver is taking a hit. His bilirubin is higher. His acetaminophen level is 12. Now, when we talk about acetaminophen levels, is if there's a normogram, and what you do is you plot on this normogram is how much you think the patient took and when they took it. So if there's an overdose, it's really hard to find it because a lot of times either the patient's not going to tell you, they could be obtunded because they took the acetaminophen with another substance and they're obtunded. You don't know. Or they may give you misinformation. So if you can use the normogram, you plot this normogram from time of ingestion or suspected ingestion with the estimated amount. And sometimes you're just guessing. And then from that, it's going to give you a graph, and you plot on this graph, and you say, above this is we need to administer N-acetylcysteine. And we'll say after 4 hours after ingestion, if it's greater than 100, you need to administer, greater than 12 hours, 30. These are numbers that you don't have to memorize because you can look at the nomograms. But the reality is, if you suspect a toxic ingestion, I can guarantee you, and when you call poison control, we'll talk about poison control. If you get called poison control, they're going to recommend you give the NAC, okay? And we'll talk about this. So what is a toxic dose? Not that much when you think about it. 12 grams over 24 hours. 12 grams over 24 hours. Or if they do 10 grams in a single dose, over 10 grams. Now think about it is, if you go to these famous outlet malls or to these wholesale warehouses and they have this big bottle of acetaminophen, usually those are extra strength acetaminophen and they're usually 500. So if you're taking, 20 pills, that's not that much, not that much. So this gentleman has taken a hit. Now, we've taken this as more of acute because he's done it over 5 days. It's not an actual acute overdose ingestion, but he's done it over 5 days. What about another person that can do this? Is, say, the 84-year-old female who's been taking acetaminophen for years. She sticks at that 3 grams. Her doctor says stay at 3 grams. Her provider says stay at 3 grams. But she's doing it over a period of time, and say she has other things going on. Her liver isn't the greatest because of other medications she's taking. Maybe her health isn't the greatest, and then her liver is kind of taking a hit. This is considered a chronic long-term ingestion, and you would consider NAC on these. This is basically the glutathione gets depleted from this chronic, even this patient's doing everything they're supposed to do right. This chronic ingestion, 84-year-old, is chronically depleting their glutathione. Okay. Now let's go back to our question at hand. This is a 52-year-old man who's been taking acetaminophen at a higher dose level than probably should, mixing it with hydrocodone and acetaminophen for acute back pain, and now we have a liver problem. So what are we going to do? What are we going to do? So what is the answer? The answer is to begin N-acetylcysteine therapy, beginning the NAC, the N-acetylcysteine, and the American College of GI recommends beginning if the acetaminophen level is greater than 20, regardless of the time since ingestion, okay? And if you happen to call it poison control, and highly recommend, if you have a patient who has overdosed, just like you would consult orthopedics for a hip fracture, highly recommend you get the Poison Control Center in your area involved. They will have a licensed toxicologist who's certified and to assist you. They can help you in easy cases and in tough cases. So the activated charcoal, not going to really work because this is delayed. Charcoal, you'll see some people discuss maybe up to 12 hours, but usually it's going to be the first couple hours where it's useful. Corticosteroids, hopefully you don't have to get a liver transplant. Now, if the patient is getting worse and they have signs, you would want to get a hold of your liver transplant team as soon as possible, and then waiting another 12 hours is not going to help us. We want to get that NAC in the system, that N-acetylcysteine in the system, to get it working as soon as possible. Now, this could be the next correct answer would be immediate liver transplant. How about instead of, if it's stated instead of getting the liver transplant, how about contacting the transplant center? That would be a good solution too, is get them on the list and get them in the field if they needed to, get them in their spectrum and get them in their discussion, okay? But not getting the liver transplant right away. All right, acetaminophen increases the LFTs, INR, and cerebral edema and vomiting. And acetylcysteine is the treatment, as we discussed. Say if the patient has anaphylaxis, guess what we need to do? We need to continue. You need to transfer to a liver transplant center if severe symptoms. So we talked, it's not that much that is required. And this is the regimen right now, and you can have adjustments to this. If someone has a very severe adjustment, contacting your poison control center, they're going to increase the speed in which the N-acetylcysteine is given, and a lot of times they'll have you continue after you finish your 24-hour routine regimen of it and keep continuing with it. And it's usually a 3-bag, 3-dose with a loading dose of 150 milligrams per kilogram and a 200 milliliter dilution over 15 minutes to 1 hour. Your second dose. Now these can be adjusted by the Poison Control Center if they feel that this is severe ingestion, and basically giving the medication over a shorter period of time so that way you're initiating another round of it. Okay, let's talk about flumazenol for acetaminophen toxicity. What it does is it causes inhibition of the CYP450. It prevents activation of the GNK enzyme. What this does is the GNK enzyme can increase the oxidative stress in the mitochondria. It's used for NAC in large ingestions, greater than 500 milligrams per kilogram, or when the 4-hour acetaminophen concentration is over 5,000. It's huge. It's a 15 milligram per kilogram loading dose, then 10 milligrams per kilogram every 12 hours for 48 hours. So if you get where the poison control, the toxicologist, or the team on the poison control recommends it, this is what they may recommend for you. Or you may need to initiate it on patients with severe overdoses. All right, let's get another board question here. Which of the following is the most appropriate next step in management? Next step in management, okay. IV diphenhydramine, intramuscular epinephrine, IV corticosteroids, inhaled albuterol, observed for regression of symptoms. Okay, so what do we got here? This is a 34-year-old female with history of peanut allergy, presents so peanut allergy, emergency department after accidentally ingesting a peanut-containing cookie. This happens. This happens. She's at a bake sale and she looks at those cookies. They said there's no peanuts in there. The person made a mistake. They eat the peanuts unintentionally and gets itching, urticaria, throat tightness, and shortness of breath. Okay, what scares us the most? Throat tightness right here. Why does that scare us? You can have the world's greatest lungs. From this hole to there needs to be a tube, and this tube right here, if it gets blocked, I don't care how great your lungs are, bad things are gonna happen to you. Oh, she's already hypotensive and has diffuse wheezing. So what are we worried about? We're worried about anaphylaxis. So what would we do? Okay, so a lot of these you're gonna say, well, I would give all of these, but what is the most appropriate? You go, well, you know, in my hospital, in my clinic, we would give all of these, but what is the one that really works? And this is your answer right here. What here? IV epinephrine. And you may say, what? What, the steroids, the diphenhydramine, the albuterol, because she has shortness of breath and wheezing? This is your answer right here, is epinephrine. Let's give you, and we're going to discuss anaphylaxis management in the full course of that. All right, let's go with anaphylaxis management. Airway management, number one, remember, greatest lungs in the world. If this tube is closed, things are not going well for you. Patients taking beta blockers can be resistant to treatment epinephrine. Glucagon for patients taking beta blockers. Glucagon has an inotropic and chronotropic effects, not mediated through the beta receptors. Adjunctive therapy. And we're going to talk about the adjunct, and then we're going to go back to the epinephrine. H1, H2 histamines does not relieve the stridor. Glucocorticoids can take several hours. Neb or bronchodilator treatment, which would be the nebulized albuterol. Let's go back to this. Let's go back to this, and we're going to talk about this. Why is epinephrine so important? Okay, well, I can give you an example. So epinephrine decreases the permeability of the vessels. It's also going to give the inotropic and chronotropic effects. This is the true treatment for anaphylaxis. And I'll tell you about an example. This is early in my career, there was an endocrinologist who flew around little private planes, and he happened to be my attending for a while. Very smart man. What he would do is he would get cases in which patients had anaphylaxis in which they did not receive the epinephrine. And these cases were very easy for him to win because he is an expert in anaphylaxis. He's an endocrinologist who specializes in anaphylaxis. When they did not receive the epinephrine is the gold standard. He would fly to these places and he would ask them to write a check. He'd say, you either write a check now for this amount or you're going to write a bigger check when you go to trial because you're going to lose because you did not give the standard of care. The standard of care is the epinephrine. The epinephrine is the true treatment for anaphylaxis. Now I know in your village, your city, your hospital, your clinic, you may not be using it, but this is the true treatment. You go, well, anaphylaxis is going to cause tachycardia. This is going to cause hypertension. Yes, it is, but it's going to get this patient alive. The rest of these things are window dressing. These are not going to take care of the airway. They're not going to open up the airway as well as fast as the epinephrine. That is the true thing. Now, here's another example of, this is something intranasal epinephrine. This is what you can offer to your patients. This is a 2 milligram epinephrine nasal spray. Has a maximum plasma concentrations of epinephrine. So let's take a look at this. And we'll talk about why this spray could be a game changer for some of your patients. This is FDA approved. Okay, so intranasal is going to get you about 258, and IM injection is going to get you out 254. The auto-inject epinephrine pen is going to be even higher. Okay, what's the problem with the auto-inject epinephrine pen is the expense of it. Also the half-life, also like the shelf life on it. It's about 12 months. This spray is about 30 months. So the price is usually reasonable. It's more reasonable on the nasal spray than it is on the auto-inject epinephrine. And when you look at it side to side, and also too is that you can have a longer half-life, meaning that you can keep it around longer. And it don't have to worry so much about storage. It needs to be, so did you need to store the Neffy or this nasal spray at a room temperature between 68 to 77 degrees? It's pretty temperature tolerant. So it can go in temperatures up to 122 degrees Fahrenheit. It's about a quarter or a third cheaper than the auto inject. So these things can be important for this. Now you should have 2 doses with this because sometimes you're going to need a second dose, and you'd use in the same nostril after 5 minutes. Now, what is the side effect is this? Can it cause chest pain? Yes. Can cause angina, can cause arrhythmias. And then if the patient has nasal polyps, this is probably not the best medication for them because it can affect absorption. Epinephrine, mechanism of action. So it has the alpha-1 adrenergic agonist effects, which are going to increase vasoconstriction, increase peripheral vascular resistance, and decrease mucosal edema. Okay, that's super important right here. The beta-1 adrenergic effects. Beta-1 is going to increase inotropy, okay, and increase chronotropy. So the speed and the strength of the heart is going to be increased with the beta-1 adrenergic. The beta-2 increase the bronchodilation, super important right here, and decrease release of mediators of inflammation from the mast cells and basophils. This is the king right here. This is the king for anaphylaxis. People miss this. They give all the other window dressing, but this is what they need to give. So I recommend, as you as a provider, that when you go workplaces, I don't care if you're working for a few hours, find out where your stuff is. Find out where your crash card is. Find out if you have an epinephrine auto-inject pen available for you if a patient has anaphylaxis or staff member has anaphylaxis, where it is, so you can administer and take care of them right away. Because when things happen, things go sideways, people start, there's chaos, and you're not able to get this medication as fast as you need to. All right, here we go, another board review question. We're gonna go with the answer, the question first, then we'll start going and we'll look at these answers. Which of the following is most appropriate next step in management? Next step, very important when we read that. Next step, IV amiodarone, high dose IV glucagon, intravenous bicarb, intravenous naloxone, and activated oral charcoal. All right, so let's go right here. A 32-year-old woman presents to the emergency department 12 hours after ingesting, oh, here we go, 12 hours. So guess what's probably gonna leave here? Charcoal. Now, you'll find some toxicologists that recommend charcoal, up to 24 hours. The reality is there's increased risk for aspiration, and usually, after 4 hours, people withhold the charcoal because the aspiration risk and maybe the risk benefit is not as good as it should be. Okay, this is the one that she has done, is taken an unknown quantity of prescribed metoprolol. Okay, so these are the ones that are gonna scare you. And we're gonna call it the triad. I'm gonna call it the triad of fear in ingestions. Somebody takes a beta blocker, calcium channel blocker, or bupropion. Those are the ones that you're gonna fear the most if you work in this realm of overdoses. All right, so this is a suicide attempt. Unfortunately, she wants to harm herself, and she has a blood pressure of 70/40. Remember, we want to protect the MAP. You're going to protect the MAP because it's so important. Heart rate of 38 in cool extremities. Why is her heart rate low? Is because she's getting beta block. EKG shows sinus bradycardia. Remember, we can count the boxes to get our bradycardia right away and know that she's bradycardic without conduction block. After administration of IV fluids and atropine, there's minimal improvement in her hemodynamics. Okay, now, with a map like this, what do we want to give? What can we give here that's not an answer? Is we probably want to stabilize with a pressor, okay? We want to get our map up. But then what would be the next thing? Say we get our pressures and our map greater than 65. I want you to always remember map greater than 65. Now, there is studies for a lower map. We possibly can consider 60, but let's think of 65 is going to be our number. So what do we want to do? High dose glucagon, okay? So we got the map corrected, but we also can use glucagon. So you're going to say bicarb, so we already talked about charcoal. We're too far out. Amiodarone, that's going to cause us a worsening bradycardia. We don't need that. Naloxone, where it's not going to work. Naloxone only works on the mu receptors for opioid overdose. Intravenous bicarbonate is not going to really do anything in this. So in this answer selection is that intravenous glucagon because it has inotropic and chronotropic capacity. We'll talk more about calcium channel blockers. And is this question truly fair? No. If this answer was here, if we had glucagon, but we also had, as a pressor, say we had norepinephrine or epinephrine is one of our answer choices, that would be the most correct, most correct. So is this a fair question? No, not a fair question, but is this a correct question? Yes, it is, and we'll discuss. All right, now continue discussion on calcium channel blocker overdose. Remember, this is part of the triad of fear that you should have an overdose. Any overdose can be deadly, especially polysubstance overdose, but here again, this is the ones you should fear is calcium channel blockers, beta blockers, and bupropion. So calcium channel blocker overdose, so we can say within 1 to 2 hours, you'll say some people say 3 to 4. There's some toxicology literature where people are taking this up to 24 hours. We're gonna stick with the 1 to 2, and that's what your boards are gonna stick with right now. Calcium will help improve hypotension and conduction services. Think about it. Calcium channel blockers, you give calcium. Glucagon gives the chronotropic and inotropic effects. It's going to speed the heart and make the heart squeeze better. Vasopressors, as we discussed. Insulin. How does insulin work? This is interesting. You wouldn't think about this. Insulin, so when you take too much calcium channel blockers, it shifts the myocardial substances from, we change it from taking the preferred of carbohydrates to free fatty acids. So it increases the insulin resistance. So if we take calcium channel blockers, our myocardium prefers carbohydrates. It prefers from carbohydrates, it wants to do free fatty acids. So, and it increases our insulin resistance. So, and it decreases insulin secretion. So insulin can be a positive inotrope. And what it does is it changes what our metabolism is on our myocardocytes. Methylene blue, what that does is inhibit nitric oxide synthesis. So remember nitric oxide, what does that do? Is it causes vasodilation, so it's going to inhibit the vasodilation. You look at methylene blue as kind of a bomb pass. This kind of can muck up your labs, kind of muck up things, but you use this when everything is going bad and you're just trying to get this patient alive. Here's another one, is lipid emulsion therapy. It sequesters the lipophilic drugs. This is another one, this is the bomb pass. This is when it kind of mucks up your labs. I do recommend it. If you give patients lipid emulsion, is when you draw labs from there, is you're gonna have to walk those down to your lab. If you put them in a tube system, that liquid emulsion, the lipid emulsion is gonna shake up, and it's gonna make your labs very hard to run, and you're gonna have to run them several times. Those, you gotta be very careful with that. This is when you go for the bomb pass, and you're just trying to get this patient alive. All right, here we go. Let's get another board question. Is this going to be fair? Probably not. Which of the following is the most appropriate next step? We'll take a next step. Well, this is this looks very similar to the other one. Is it not? Okay. So we have the choice of what? We have a choice of bicarbonate. We have a choice of charcoal. Remember, this right here, we say 12 hours from ingestion. This is charcoal, so we probably take that out right away. So this is what you do, is you work through and you try to eliminate what you can. Dextrose, fat emulsion, and intravenous naloxone. Very similar. This is extended release diltiazem. Extended release diltiazem in a suicide attempt. Well, what is diltiazem? Diltiazem is what? What is this? It is a calcium channel blocker. So this is kind of a trick question, not fair. We're doing back-to-back calcium channel blockers, so we kind of get a different picture, so that way you can be able to handle different scenarios on your boards. Here we go, low blood pressure. This one's going to show a first-degree AV block, and we have, despite 2 liters of intravenous fluid, they're given 1 milligram of intravenous atropine. Hemodynamics do not improve. what are we going to give? You should already know this answer because we went through this, okay? High dose intravenous insulin with dextrose. So you're going to use the dextrose to get the sugars up, and that way you get the insulin to, then you can use higher doses of insulin, and the insulin is going to have an inotropic and chronotropic effect, and it's going to help the way the calcium channel blocker, it's going to change the way it uses metabolism of the carbohydrates, okay? And it's going to decrease that insulin resistance short term. All right, here we go. Beta blockers, calcium channel blockers. What's the side effects? Bradycardia, hypotension, and altered mental status in beta blockers. You give atropine 1 milligram IV times 3 doses, glucagon and calcium chloride, vasopressors and transcutaneous pacing, high-dose insulin and glucose. And here again, we can use lipid emulsions. Add these treatments in sequence or all at once if severe in presentation. Remember, these are the scary people right here. The beta blockers and calcium channel blockers, you're going to be treating them roughly the same way. All right, it's an 18-year-old female with an empty bottle of bupropion. Okay, this is a scary one. First of all, this is a young person, probably no past medical history, and unfortunately, they decided to harm themselves, okay? And these are the cases that give you PTSD. These are the ones where if you don't treat them right and treat them effectively and fast, you will have PTSD because they will pass. Bupropion intoxication. If you talk about bupropion to someone who is a toxicologist, they feel this medication should be removed from the market. I'm not saying it should be removed from the market, but it is very severe toxicity. And how much are we talking about? It's not that much. So if they have the 400 milligrams, we're talking about 8 pills. 8 pills, that's not that much. If they're taking 25 pills of the 150, that can be enough for intoxication. So these are pretty scary, okay? And it's going to be a scary ingestion, and it's really not that large of an ingestion too. So inhibition of dopamine and norepinephrine reuptake. Cardiotoxicity, this is the big thing, is inhibition of gap junctions. You have a prolonged QRS and systolic heart failure. And blockage of the cardiac potassium channels, you're going to have an increased QTc. So you're going to have hypotension, increased QTc. Urine drug screen can be positive for amphetamines. The dosing 3 grams can cause a seizure, 10 grams can cause toxicity. So it's pretty scary in what can happen. So 3 grams can cause a seizure, okay? And 10 grams can cause toxicity. So pretty scary. Let's talk about this more about the bupropion intoxication. You're going to have the latent phase, sustained release, so that's the longer acting release, be 24 hours. Then you have the neurotoxicity with the dilated pupils and delirium, can have seizures, and then usually the later stages is going to be the cardiac toxicity, where you have the prolonged QRS, prolonged QTc. So what can you use? You can, if it needs to, if you're having refractory shock, this is when you consider VA ECMO. These are usually young people who unfortunately have decided to harm themselves, and we need to get them back and get them better, and then they need to get treatment. Treatment can be whole bowel irrigation. This is in sustained release, okay? This is a little bit different because this sustained release over 24 hours, you can try whole bowel. Supportive care, intubation, vasopressor, you can use the lipid emulsions, and then you're using your bomb pass of the VA ECMO. And we're going to talk about ECMOs.